Greetings and a warm welcome to all the dignitaries present here. I am Ria from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet proudly stand as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by Indian College of Anesthesiologists. And the focus for today's session is clinical outcome scoring in intensive care unit. Now, I would like to invite Dr. Mukul Kapoor, sir, for the further proceedings. Over to you, sir.
Thank you very much, Ria, and welcome all of you to the 288th webinar of the Indian College of Anesthesiologists. It's been a very long innings for us when we are continuing without fail to deliver these webinars for the last a few years. And I welcome you all to this edition of the webinar also. The webinars have been continuing incessantly, and we have been enriching students across the country for the last many years. It is very important to understand what is the role of ICA. ICA has been involved in the education of anesthesiologists across the country, not only students, but also fellow anesthesiologists. And we have been constantly only stressing on education and nothing else but education. In addition to running webinars, we run multiple other activities in the ICA. The activities include running multiple fellowship programs. We have been also granting fellowships of the ICA over the years. Apart from this, the ICA runs some very prestigious academic books. One is the Journal of the Indian College of Anesthesiologists, which has been running for the last 4 years. And the second is the Yearbook of Anesthesiology, which has completed more than 15 years. And the Yearbook of Anesthesiologists has been a sort of an iconic publication in the field of anesthesiology in our country. We are very proud to say that almost every examination across the country, the recent advances paper is generally picked up from the Yearbook of Anesthesiology, which is something we have pride on because we have sort of become recognized as the most important organization which is delivering the recent advances to the students of anesthesiology. The ICA is also involved in other kinds of activities like holding the quiz. Last year, we held a quiz in which we gave away some prizes, and the quiz was a grand success. I would also like to inform you the ICA every year has the annual conference, and the annual conferences are gradually getting very popular. This year, the annual conference will be held at Aligarh. It will be hosted by the Jawaharlal Nehru Medical College, Aligarh. And the dates of the conference are 11th to 13th of September, with 11th September having the workshops and 12th and 13th September having the main conference. I invite you all to register for this conference and enjoy really high levels of academics, learn from it, also meet your fellow colleagues, your fellow anesthesiologists from across the country, and gain a lot from this conference. Now going towards the webinar of the day, and the webinar of the day is on the subject of scoring in the intensive care unit. And scoring in the intensive care unit has recently acquired great importance, with even the accreditation bodies insisting on patients getting scored in the intensive care. There are lots of scores which are there to decide what is the morbidity and mortality and the outcome of patients in the intensive care. And today we have the team from the Titankar Mahavir Medical College, Moradabad, which is going to educate us about different parts of different types of scoring which are available. And to head this and moderate this particular webinar, we have Dr. Pallavi Ahluwalia. Dr. Pallavi Ahluwalia is the professor in the Department of Anesthesiology at Tankar Mahavir Medical College and Research Center. She also holds the post of President of the Indian Society of Anesthesiologists of the Moradabad City branch. She is the proud holder of the Fellow of the Indian College of Anesthesiologists. She also has a fellowship of the Royal College from Glasgow. It's a IMSA fellowship and in palliative medicine, and of course is a member of the National Academy of Medical Sciences, has also done PG diploma in health management. Apart from this, her special areas of interest are regional anesthesia, critical care, difficult airway, and obstetric anesthesia. She has a special interest in ultrasound blocks and pediatric anesthesia. She has about 80 publications in national and international journals and has written chapters in the Yearbook of Anesthesiology, and is also the editor of a book which was written by her, that is the Handbook of Perioperative Analgesia. Apart from this, she is editor-in-chief of IJAA and ex-editor-in-chief of IGCA, that is IJ's. It's a part of the Indian Journal of Anesthesiology for the Central Zone, and she's the editorial board member of the JOACP also. So now I hand over to Dr. Pallavi to take the proceedings further.
Thank you so much, sir. Thank you so much for the kind words and introduction. I'll share my slide. So let me start. So is my PPT visible?
Yes, ma'am, it is visible.
Okay. So before I start, I have a disclosure that is my full screen visible?
Yes, ma'am, it is visible
Okay.
in full screen.
Okay. So I do not have any disclosures or any conflicts of interest. Okay. So today we'll explore, sorry. Thank you so much for joining me today on this important webinar. I'm Dr. Pallavi Ahluwalia. So today we'll explore the tools that guide our clinical decisions in ICU every single day. Over my years in anesthesia and critical care, I have learned that the difference between good and exceptional patient care often lies in our ability to objectively assess the severity and communicate the risk. This presentation will equip you with the practical knowledge to apply these systems confidentially in your ICU. So by the end of the session, you will understand not how just to calculate the scores, but also why they matter in our clinical practice. We will move from fundamental principles, understand the difference between the severity assessment and mortality prediction, through to a real-world application of Apache, SAPS, and MPM scores. We will also discuss the limitations and proper use of these tools. These are not just academic exercises. They directly impact on how we allocate our resources, discuss the prognosis with the families, and benchmark our ICU performance against the standards. So for decades, we relied on the clinical judgment alone, the experienced eye, the gut feeling. But the fundamental problem with that is that two equally experienced clinicians can assess the same patient and reach different conclusions. Our impressions are influenced by the last patient we saw, our personal bias, and even our mood that day. So we can solve this by standardizing the scoring systems. And the standardizing makes it reproducible. If I score a patient today and you score a patient tomorrow, we will get comparable results. So this consistency is crucial for communication with the families, to justify ICU admission, and to compare the outcomes across different institutions. And they give us a language to communicate. Rather than saying that I think the patient is very sick, if I say that a patient's Apache 2 score of 35, and that indicates 80% predicted mortality, that will be more objective in defining the condition of the patient. So every scoring system has Every scoring system has two critical components. First is the severity score, which is a numerical summary of how deranged the patient physiology is, and other is the mortality risk prediction, which is calculated based on the complex equations and complex computer-based algorithms, which help us in predicting the mortality of the patient in the ICU. So the score is just a number based on the sums and the weights of the specific variables which are noted. And these scores were built on prospectively collected data. Each score has a particular time frame from which the data is collected, and that needs to be followed. The predictive scoring systems are a measure of disease severity and mortality. And this is the complex equation which is used to calculate mortality or predict mortality. So before starting this, first we need to know why do we need scoring system. So we need scoring systems for clinical decision making, they help us guide the treatment and allocate the resources. The scoring system help us in quality benchmarking, and they are by using them we can compare the quality of the patient care across the ICUs. They help us standardize the communication and communicate about the disease severity of the patient. They help us in clinical trials and for making the protocol. So they help us risk stratification. They help us to predict outcome, and they standardize the resource utilization by utilization of these scores in the research and the resources. So there are various ways to classify scoring system. One is the anatomical score, which are based on the anatomical area involved. These scores are mainly used in trauma patients. For example, abbreviated injury score or injury severity score. Then there are scores which are based on the assumptions that very ill patient will require more complex interventions. So we have a therapeutic weighted scores like TIS, that is therapeutic intervention scoring system. Then they can be based on the number of the organs involved, and or they could be organ specific. For example, SOFA, that is sequential organ failure assessment score. Then we have physiological scores, which are based on the degree of derangement of the routinely measured physiological variables like Apache and SAPS. And then we have disease-specific scores. For example, Ranson's criteria is there for acute pancreatitis. We have MELD model for liver failure. So to summarize, we have a disease-specific scores like GCS for neurological patient or Ranson's, and then we have generic scores which can be applied to all patient populations, and then they can be further divided into disease severity score and organ dysfunction score. Then they can be classified based on first day scoring or repetitive scoring. First day scoring systems are usually calculated in first 24 hours of ICU admission, and the worst readings are noted to calculate the score. And then we have repeated scoring, which are the scores are assessed on a daily basis or a shift basis to give us a trajectory of the patient, whether the patient is improving or deteriorating. A more logical classification would be to classify them into three groups. First group would be score that assesses the severity of the disease at the time of admission to predict the outcome of the patient. The examples are Apache, SAPS, and MPN. Second would be the scores that evaluate and the presence and severity of organ dysfunction, like SOFA, LODS, and MODS, and scores that assess the nursing care and evaluate the nursing workload. For example, TIS, nursing activity score, etc. So today also we have divided our seminar into these three subheadings, and we'll be discussing accordingly. So before delving into the scoring system, just few brief statistical concepts which are repeatedly, you'll come across repeatedly and which are used when we define the scoring system. First is the calibration, which tells us whether the predicted mortality actually matches the actual mortality. So this assesses the degree of correspondence between the estimated probability of model versus the observed probability. So as you can see in this figure, the two groups, the blue, one in the blue and one in the red, they are not calibrated, and there's a lot of difference between these two findings. So this is a poor calibration in which the predicted mortality is supposed 10%, but actually only 2% of the patients they die in the ICU. So good calibration, the results, the predicted mortality matches the actual mortality. The next concept is discrimination, which means the ability of the score model to discriminate between the patients who die from those who survive based on the predicted mortalities, and that is done using AU-ROC curve, that is area under the receiving operative curve. And this is how the curve looks like. And the greater the area under the curve, the better the discrimination. Point 8 is considered to be a good discrimination. Point 9 is excellent. And point 5 is just like a random guess or like a flipping a coin, and which is unacceptable. So this is how we compare the various scoring systems and whether they have a good discriminating ability from the survivors and the non-survivors. The next is the validation, whether the score that you are using is validated in the population that you are using. So it is a process of evaluating the accuracy of the score that it produces. So if the validation fails, then what do? We need to customize that score according to our institution, our regional or national level. And this was followed by a SAPS-3 model in which they uh, designed customized equations for different geographical areas to make it more validated in that population in which it is being used. Another term is standardized mortality ratio. So SMR is crucial for quality assessment and performance comparison. This is adjusted to see the patient severity and if the actual death matches the predicted death. The formula is observed mortality divided by the expected mortality. So this SMR is more objective than raw death rates in the ICU. So when we calibrate the score, we use this SMR. So what are the qualities of ideal scoring system? So it should be based on routinely recorded variables, should not impose another additional burden on the patient to get these values done, which are not required, just to put those findings, those values in the chart and then calculate the score. It should be well calibrated, should have a high level of discrimination, should be applicable to patient population, and can be used in different countries. And the ideal scoring system should be able to predict the functional status or the quality of life after the ICU discharge. And the other few characteristics also we need, like it should consider comorbidities and should provide a common language for communication. But till now, no scoring system incorporates these features. So this is the timeline of development of scoring system in medical and surgical ICUs. The first score to come was Apache, sorry, which came in 1981 and was published by William Noss. And then over the period of 5 years, we had various versions available. And currently we have SAPS 2 and Apache 4. So coming to Apache. Apache stands for Acute Physiology and Chronic Health Evaluation. So this was developed in 1981. And then this is divided into two sections, the physiology score, which assesses the degree of acute illness, and pre-admission evaluation to determine the chronic health status of the patient. The Apache score system was not designed to assist in individual treatment, rather to classify a group of patients based on the basis of the illness, severity of the illness. So this we have to remember that it is not for the individual prognostication, but rather this is applicable to a group of patients. So the original Apache, the worst values in first 32 hours were taken, and it had 34 physiological measures, and the chronic health was classified in from A to D. A, excellent health, and D, patient with severe organ system insufficiency. So this was a very vague type of categorization. Then came Apache 2, the same authors in 1985. They came up with the newer version, that is Apache 2, in which they reduced the number of variables to 12. And this was measured during first 24 hours of admission, and the maximum score was 71. So they estimated the risk of in-hospital mortality using logistic regression equation. Children were not included in this scoring. So Apache 2, the score ranges from 0 to 71. So it is a addition of three components. One is the APS, that is acute physiology scoring. Then we have age points and then chronic health points. So these are the 12 variables which are included in Apache 2. We have heart rate, mean arterial pressure, respiratory rate, temperature, GCS. Then we have variables derived from the venous blood, that is hematocrit, WBC, sodium, potassium, and creatinine. And then we have variables from ABG, that is pH and PaO2. So this is how, if you look at this table, this is how Apache 2 looks like. These are the various parameters which are taken into account. For example, we look at the mean arterial pressure. So BP of 70 to 109 is given a score of 0. And then on the either side of the spectrum, the score increases. For example, the BP rises to 110 to 130, the score of +2 is given. BP above 160, the +4 score is given. And likewise, on the other side of the spectrum, if the patient develops hypotension, the BP falls below 49, so the score of +2 is given. So likewise, for any derangement on either side, the scores are given from 0 to 4. So this Apache 2 also gives weights for the age. Patient's age less than 44 gets a 0 point, while more than 75 years old patient gets 6 points. And also GCS is a part of Apache 2. The chronic health points are divided into, suppose a patient is a non-operative patient, 5 points are given. Emergency post-operative patient, 5 points are given. And elective post-operative patient, 2 points are given. And the chronic health conditions included are the organ insufficiency or immunocompromised patient with hepatic insufficiency, NYHA class 4 patient with severe respiratory disease, and patients on chronic dialysis. So these are the chronic conditions which are included in Apache 2. We are also familiar with GCS, and the GCS is, as I mentioned, it is a part of Apache 2 which is calculated. So how to interpret Apache 2 scoring? So if the score ranges from 0 to 2, the predicted mortality in medical ICU is 4%, and in surgical ICU it is 1%. And as the score increases, for example, more than 34 score, the mortality in medical ICU is 85%, and mortality in surgical ICU is around 87%. But there are few limitations of this Apache score. There is no adjustment for the measurements obtained after the intervention. For example, after hemodynamic support or mechanical ventilation, or if the antipyretic therapy is given. And there is exaggerated penalty for the old age. Patient more than 65 gets 66 points, while a patient with severe respiratory illness with PaO2 alveolar arterial gradient of more than 500 gets only 4 points. So this doesn't fit well into the weights. There is no consideration for cachexia or malnutrition in chronic health condition. And this is a very static score. It is evaluated only once in the first 24 hours of admission. So this lacks dynamic reassessment. This is not validated in pediatric patients and does not consider the recent technological advancements in patient monitoring or biomarkers. So manual scoring can be time consuming without automated tools. And so it may underestimate or overestimate the risk in certain populations because of data recording errors. The scoring is as good as the data you feed inside the score. So various apps are nowadays available. This I took from MD Cal. This is a online Apache score 2 score calculator in which you feed the values and then you get a score. Now coming to Apache 3, this was released in 1991, and this was developed with the objective of improved statistical power, ability to predict individual patient outcomes, and identify the factors in the ICU that influence the outcome variables. There are two versions. Initial was a version H and later came the version I. So it has 66 specific diagnoses and 12 organ system related categories. And this is used to predict equation for mortality rates. So this total score ranges from 0 to 299. This has 17 physiological variables. This includes acid-base disturbance. Worst GCS scores are taken. Age is given weight. 7 comorbidities are included except cardiac, respiratory, and renal. ICU readmission is also taken into account, whether the patient is readmitted in the ICU. And location prior to ICU admission is also taken, and that prevents the lead time bias because patient may get stabilized in emergency medicine department, and then patient will come to ICU and patient will be stable. The Apache score will be low. So whether the patient was shifted to ICU from home or from a emergency department in which where the patient was managed for 3-4 hours, patient was resuscitated, patient was the inotropes were started, and the patient is now stable and now shifted to ICU. So these things are considered, and they help in preventing the lead time bias. So this is how Apache 3 looks like. These are the parameters which are included: the mean arterial pressure, temperature, pulse, respiratory rate, PaO2, WBC count, etc. So we have out of 299, 0 to 252 are chronic are physiological scores. The chronic health evaluation ranges from 0 to 23 and age from 0 to 24. Acid-base disturbance was given a greater emphasis on in Apache 3, and because it reflects the greater metabolic and respiratory derangements in a patient. Age was scored and weighted scores were given according to the age of the patient. These are the chronic health conditions which are included in Apache 3. A patient with HIV positive gets a score of 23, patient with hepatic failure 16, lymphoma 13, and likewise for various comorbidities, various scorings are given. This table compares Apache 2 with Apache 3, and the Apache 3, the prediction of 50% mortality is 88.2, while in Apache 2 it is 85.5. Then we come to Apache 4. This was published in 2006, and this is much more complex. It has 142 variables and need a web-based calculation, and this was developed and validated in ICUs of USA only. This is how Apache 4 looks like. These are the things which are to be filled in this Apache 4: the temperature, the physiological scoring. Then we have to feed in the data, that is the chronic health condition of the patient, the length of pre-ICU stay, whether the patient is readmission to the ICU or the patient has undergone any emergency surgery, and whether the patient's admission diagnosis is non-operative or post-operative. So likewise, this Apache 4 is calculated. This table compares the various versions of Apache 1, 2, 3, and 4. So what we have to note is that initially the selection of variables was based on the panel of experts who decided what variables are to be included in the scoring system. But later versions had a multiple logistic regression, which was used to select the variables. And as the Apache advanced, the number of criteria also, number of variables has also changed. Initially, it was 32, then 17, and then Apache 3 had 26, and Apache 4 takes into account 142 variables. So coming to the overall limitation of Apache, it needs validation in the population where you are using it, and it may not accurately predict the outcomes in special groups like pediatric and pregnancy. It needs a periodic calibration because the score developed in 1985 may not be valid today because of advancements in the antibiotics, advancements in the dialysis. We have latest treatment modalities which are available with us. So you need to periodically calibrate these scores, or else they will overestimate the mortality. Then, like I mentioned, there are chances of lead time bias in Apache 2. And Apache 3 and 4 are extremely complicated and they need a computer software for the use. So coming to second scoring system, that is SAPS, Simplified Acute Physiology Score. I'm sorry. SAPS was released in 1984 As an alternative to Apache scoring, this was developed by European group, which they wanted a simplified score. And so they reduced the number of variables to 14, and the scores were obtained within first 24 hours of ICU admission. Later came SAPS 2 and SAPS 3, in which they reduced the variables further to 12. And they also included, just like Apache, they included the weights for the pre-admission health status and the age of the patient. So this is how the SAPS predicts the mortality. And if we see the SAPS 2 has a better discrimination, AUROC is 0.86 compared to the previous version, SAPS 1, which is 0.8. So SAPS 2 was developed in 1993, and it was a multicentric study. It included around 13,000 patients across various ICUs. The type of admission to was considered. Then physiological measurements like heart rate, blood pressure, temperature, etc. were noted, and various lab investigations were also noted. And the score ranged from 0 to 163. So this is how a SAPS 2 score looks like. So these are the parameters: heart rate, systolic blood pressure, temperature, urine output, creatinine, urea, and so on and so forth. And likewise, the scores are given to the uh, change from the normal physiology. Then it also, as I mentioned, it includes the chronic diseases, the type of admission, and the age. Next, SAPS 3 came in 2005. The advantage was that it required the data to be collected within 1 hour of entry to the ICU. So this allows for a better outcome prediction before the ICU intervention occurs. So it is better evaluated for individual patient rather than the whole ICU. It includes 20 variables and also considers the scores prior to admission, at the time of admission, and acute physiological derailments. But the problem is that you need time to collect the data, and you may not have all the parameters required or all the investigations in hand within first hour of ICU admission. So this can have a greater missing information. Coming to the last score, that is MPM, or the mortality probability model. So this was developed in 1990. The advantage is that it is a dichotomous score. It is either yes or no. For example, the cancer, whether it is present or absent. If it is present, it is 1. If it is absent, it is 0. For the patient is having CRF, if it is absent, it is 0, and present 1. So dichotomous, 0 or 1 is given, except for the age, which is noted as per the actual number of years of the patient. So on admission, MPM is MPM 0. It included 11 variables. Later on, it had also various versions like MPM 24, MPM 48, that is 48 hours after ICU admission. The more important thing is the MPM OT, that is MPM over time. So it subtracts the MPM 24 minus the admission score. So this gives us a trajectory of the patient, whether the patient is improving or deteriorating. Likewise, we can calculate MPM 48 minus MPM 24 to see the recovery of the patient, or whether the patient is deteriorating. So MPM OT is better than MPM 0. Lastly, what is the future? Traditional scores, they misclassify the patient due to exclusion of relative risk factors in the score. They don't include the complications that arise during the ICU treatment, and the treatment effects that modify the outcome are not considered. So nowadays, there is a shift from static to dynamic scores, which have better discriminating ability compared to the traditional score. So now we have a real time, or the living scores. So instead of a single score at 24 hours, the machine learning algorithm, they ingest the streaming data from the electronic health records, like vitals, the labs, the ventilator settings, and they update the risk scores every minute. So we get a trajectory rather than a status. So a rising machine learning based risk score can alert you to deterioration before even the BP drops. So you can manage preemptively the patient. Another thing is that these machine learning models are the previous version, the traditional system, they relied on the logistic regression, which is a linear approach, which assumes that the variables they interact in a simple additive ways. But that's not the case. So the machine learning models nowadays they use various statistical models like random forest, gradient boosting, and neural networks, which thrive on non-linearity, and thereby they give a better prediction compared to the traditional scores. So we have all seen this. The study was published in 2020, which used this hybrid neural network approach, which was used to continuously and automatic mortality risk prediction using vital signs in intensive care unit. Another study which was published, a super learner ensemble of 14 statistical learning model was tried for predicting COVID-19 severity among the patient with cardiovascular conditions. So new models are coming. We have daily advancements in the machine learning, and soon we'll come up with a new model. But there are a few limitations of these machine learning based models. First is that these algorithms are as good as the data that we feed them. Electronic health records do not know how the data is being recorded. Then we can have missing data, which can lead to bias because the missing variables are considered normal. Then patient with maximum data would appear to be sickest. So that is again a area which can lead to bias. And then deployment of these tools is quite cumbersome. So after discussing all these scores, finally we should conclude which score to use. So the previous models are only of historical importance. The most widely and accepted score which we use even in our ICU is Apache 2. SAPS 2 is very common in Europe. Apache 3 needs a proprietary algorithm for calculation, so it is not in public domain. SAPS 3 and Apache 4 are better designed, but they're validated for use in ICU of USA only. Apache 4 is more accurate, but then it has 142 variables, so there is a high burden of data collection and it is costly. And SAPS and MPM are less data intensive, so you may not get the accurate prediction of the mortality. So to conclude, the scores need customization before use, but at the cost of loss of comparability. The scores can be used to compare study population in randomized controlled trials and to assess the ICU performance. They should not be used for individual patient management. Scores to assess the quality of intensive care, ISAP Apache 2 score is accepted universally as a gold standard. So trends or the trajectory matters more than the single values which are recorded in the first 24 hours. And machine learning is the future. Thank you so much. Thank you for the patient listening. Thank you. So thank you so much. If there are any question answers, we'll take up at the end of the session. And with that, we'll proceed to the next talk, which is by Dr. Shambhavi. So, Dr. Shambhavi, please share your slide.
Yes, ma'am. Thank you. Is it visible now, ma'am?
Yeah. So I'll introduce our next speaker, that is Dr. Shambhavi Chauhan. She's done DM critical care, and she's presently working as consultant critical care medicine at Tirthankar Mahavir Medical College, Moradabad. Her areas of interest are focus, advanced hemodynamic monitoring. She is very talented and she's won various awards like Young Talent Hunt Award at Criticare 2020. She has received GK Sinha Young Researcher Award. She has presented various papers in various international and national conferences, and she has published 6 publications, and she is a member of various societies. So now I welcome Dr. Shambhavi to give a talk on the organs failure assessment scores.
Thank you so much, ma'am. So I'll be discussing the organ dysfunction scores. In this presentation, I've included these five scores: SOFA, MODS, LOTS, ODIN, and TRIOS. And out of these five scores, I'll be discussing SOFA in detail because this is one score which we use daily for clinical purposes, and for statistical purposes also it is used most commonly. As you can see, all of these scores were developed around 25 to 30 years back with the aim of describing quantitatively and as objectively as possible the degree of organ dysfunction in ICU, and also their temporal relation, the changes with time. And few of them also had one formula to define the predict the mortality, like Lords, Odin, and Trios. But SOFA was not one of them. The original paper in which SOFA was published in 1996, there was no mention of prediction of mortality. It was purely an organ dysfunction score. So, unlike the outcome prediction scores, organ dysfunction scores are usually dynamic. They are repeative scores. Why? Because organ dysfunction itself is a continuous process rather than an event which has to be graded objectively. Also, the outcome in ICU depends definitely on the day one, and it also depends on the subsequent course of illness and our management. If we repeat the scores, we'll have some idea that whether our treatment is effective, or if the organ dysfunction scores are worsening, will probably there is need for escalation. And as ma'am mentioned previously, we can also use it for resource optimization. For example, if we have one patient in ICU with SOFA score of 20, and there's another patient with SOFA score of 2 or 3, so we can ask the nursing in charge to allocate the staff in 1:1 ratio for the sicker set of patient, and in 1:2 or 1:3 ratio in the patients having lesser SOFA. So this is the SOFA score, sequential organ failure assessment score. Also, initially it was called a sepsis-related organ failure assessment score. It was created in a consensus meeting of European Society of Intensive Care Medicine in 1994, and it was further revised in 1996. As we know, it includes 6 organ systems, and these are graded from 0 to 4. The score ranges from 0 to 24, indicating higher the score and more the organ dysfunction. So, as I have said initially, there is no direct relation of SOFA score with the mortality, but with certain evidence, certain RCTs were published. With that, we have some rough estimate of mortality. So we can say if SOFA score is 10, then mortality in ICU probably it is around 50%. Now, what is delta SOFA? Delta SOFA is change in total SOFA score or that of an individual subscore between a defined time point and the baseline value. For example, if a patient has come with pneumonia ARDS, day one SOFA score is 4, and by the day two, his ARDS has worsened, hypoxemia worsened, PF ratio has decreased. So now SOFA score is 6. So we can say delta SOFA is 2, or we can also say the respiratory delta SOFA is 2. So before SOFA score it was published in 1996. So since then, it was not used very frequently until it was included in the sepsis 3 guidelines. They have used it for defining sepsis. They have mentioned for clinical operationalization, organ dysfunction can be represented by increase in SOFA score of 2 or more, and it is also associated with in hospital mortality greater than 10%. And Again, it was substantiated in the in this systematic review and meta-analysis. They have said treatment effects on delta SOFA appear to be reliably and consistently associated with the mortality in RCTs. Although fixed SOFA was most frequently reported outcome, but still it was not significantly associated with mortality. So they also recommend using the delta SOFA. So in the span of 30 years, there were many modifications of SOFA were published. Modified SOFA with small m, with capital M, modified cardiovascular SOFA, extra renal SOFA. In these scores, they have omitted one organ system, and then according to their need, according to their subset of patients in their ICU. And there was Cliff SOFA, which was used for, it's still in use for acute on chronic liver failure. Then Q SOFA with lactic acid. But all these scores, none of them had much clinical significance because they were derived from studies from single center, and they lack the reliability, they lack the validation for a larger set of patients. On larger scale, they were not validated, so none of them were accepted except this quick SOFA. Quick SOFA was used frequently until recently. So in this score, they have included three variables: respiratory rate more than 22, change in mental status, systolic blood pressure less than 100. And if these are present, we give 0.1, otherwise 0. And if score is more than equal to 2, it indicates the poor outcome. Quick SOFA also, it was recommended in the sepsis 3 guidelines for out of ICU purposes, for in out of hospital emergency department wards. They recommended it to use to recognize the patients who are more likely to have poor outcome. But in 2021, in the surviving sepsis guidelines, they have recommended against the use of QSOFA compared to systemic inflammatory response syndrome or national early warning signs or modified early warning signs as a single screening tool for sepsis or septic shock. So, although none of the modifications of SOFA were accepted universally or largely, but it doesn't make SOFA score perfect. It has because over since 1994, a lot has changed in terms of how we treat the patient. There are newer drugs have come up, newer interventions have come up, and definitely, score which was made 30 years back, all of these things makes it a little inaccurate, not validated to the current scenario. So if we discuss the limitations of SOFA, according to the system wise, for respiratory system nowadays, we try to keep a higher threshold for intubation. Various non-invasive strategies have come up. We use CPAP, BiPAP, HFNC. So none of them are included in SOFA. Also, ECMO is used in tertiary centers, some tertiary centers, which is also not included in SOFA. In renal system, if we schedule a dialysis, if we do a hemodialysis session, it will be the creatinine level will be lowered, and then it will give a false low score of SOFA. Whereas the patient has actually worsened, patient is now requiring dialysis, but SOFA score it will be improved if we take the creatinine value. And then in CNS, it is very difficult to assess GCS in sedated patients who are mechanically ventilated. Sometimes we cannot stop the sedation who are in severe ARDS and for day 1, day 2. And then platelets after transfusion, it will lead to lower SOFA score values. And in CVS also, in original SOFA, they have mentioned only dopamine in the second point. Whereas nowadays we don't, there are very few indications of dopamine. And at that time, dopamine was used as first line agent. Nowadays we use norepinephrine, epinephrine was vasopressin. So guidelines have changed, newer drugs have come up. So, so far definitely needed an update. And this was many articles have come up indicating that SOFA needs an update. This I'm mentioning a few. This article was published in 2024. They have mentioned possible additions on alternatives for the consideration, change in this all in the organ systems. And this article have mentioned the inter-observer variability. Despite being such an objective score, there was inter-observer variability. It mentioned it. Explained if we asked to assess they asked to assess the GCS score, the SOFA score for the same patient, there was variability according to the level of experience. So in the coagulation and liver system, there was excellent replicability. There was less variability because probably because there is there is precise cutoff based on the laboratory values alone. Whereas in CNS and renal systems, there was very poor um, relatability, very much variability because of probably the use of sedation and use of renal replacement therapy. So all these things, all these limitations were there with SOFA, are there with SOFA, which has led to the development of this new score, SOFA 2, which was published recently last year in October 29. So in this code, they have collected data from around 1,300 ICUs spanning over the 9 countries, involving data from Nepal as well. And then they have used the modified Delphi process to guide the data of these 3.3 million patients. And initially, they were planning to add GI and immune dysfunction systems as well in the score. But then, despite having good prognostic validity, they were not able to collect the sufficient data, and there was lack of content validity. So, for example, a person can have raised white blood cell counts if in infection, but that does not mean that it is an organ dysfunction. It may be a normal response to an infection. So because of all these reasons, say they included on all those 6 organ dysfunctions only, which were there in the original SOFA score. But the scorings they have improved, they have made it very precise, and we'll discuss uh, according to the system wise. So in respiratory system, SOFA 2 has included SF ratio, that is SpO2 by FiO2 ratio, in for all those resource limited ICU settings where where ABG machine is not available, or we are not able to do ABG daily. We can assess SOFA score according to the SF ratio. And they have included the advanced ventilatory support, which includes NIV, CPAP, BiPAP, HFNO, and patients on ECMO, they have included in the 4th point. Then in renal system, they have retained the creatinine cutoff, creatinine values for the scoring, and they have included the urine output, more or less similar to the Akin or Kedigo classification of the urine output. And in 4th point, they have included the patients receiving RRT, including the chronic use. Also, if they meet the criteria for RRT. And if you're not doing it for any of the reason, patient is not giving consent, or patient is very sick, you don't want to do it, whatever reason. But if the patient meets the criteria for RRT, it will be scored as 4. Cardiovascular, very precisely, they have mentioned now the name of drugs, the dosage of drugs, the how to calculate the dose. They have mentioned you have to use the base drug. As we know, norepinephrine 1 mg of base is equals to the 2 mg of norepinephrine bitartrate. So we have to use the base, and infusion has to go on for 1 hour for it to be calculated in the score, to come in the score. And all the patients receiving mechanical cardiovascular support, VA, ECMO, IABP, LVAD, everything will be covered in the 4th point. So, or for dopamine also, they have given the points if we are using it. And in for CNS, they have mentioned We definitely we check the GCS after stopping the sedation. But if we are not able to stop the sedation, we can use the best GCS known before sedation, or we can use, if we are not able to assess all the three variables of GCS, we can just use the best motor response to grade the score. And most importantly, even if the patient is receiving treatment for delirium, patients requiring drugs to treat it, then we have to score 1 even if the GCS is 15. For liver, they have just changed the cutoffs in 1 and 2 points. They have made it 1.2 to 3 and 3 to 6, and 3 or 4 points are the same. And for platelets, they have changed the cutoffs in 3rd and 4th point. The rest is same. So I think it is very beautifully thought of, explicit scoring, standard definitions. They have involved the chronic organ failure as well. So better applicability definitely, but still, although it was validated using the very external validation was done using very heterogeneous data, but still it requires prospective validation to confirm the reproducibility in our ICU. And probably in future it may be incorporated in electronic health records and the automated scoring. So this was all about SOFA modifications and SOFA 2. Now we'll discuss a few points about the other scores. MODS, it was developed in 1995, single surgical ICU, tertiary level teaching hospital involving around 692 patients. It had similar 6 scores, only the variable used for cardiovascular assessment was pressure adjusted rate, and it had some mortality prediction also according to the score. Then logistic organ dysfunction score, it also had the same 6 organ dysfunctions, but it used to have the 12 variables. And it initial SOFA and MOTS, they use panel expert for guiding the data, but it used the logistic regression analysis. But it was again not accepted on the larger scale. Odin was developed in 1993. It was recorded in the first 24 hours. It had 6 organ system dysfunction with along with the infection with clinical evidence. Trios, 3 days recalibrated ICU outcome score. It was developed in 2001. It is a composite score. It includes transfer from ward, chronic illness, SAPS2 and LOTS on admission, and change from SAPS2 score from day 2 to day 3, and LOTS day 2 to day 3. So it includes the patients hospitalized for more than 72 hours. And then the data is to be put on the algorithm to calculate the mortality. So we have so many organ dysfunction scores. If anyone asks which is the best score, which is to use, so many studies were done comparing all these scores: MODS, SOFA, MODS, SOFA, and LODS. So, but the all these studies, they are, most of them are single centered. We're taking the retrospective data, they lack the reliability. Some of the studies, they said a SOFA score is better for cardiovascular dysfunction. Some said, sorry, LOTS is better for neurological dysfunction, but they lack the reliability. I think to choose the score which is validated, as ma'am said, it has to be validated in and then customized to our ICU setup. Then only we can consider it best for us. To summarize, organ dysfunction scores should be used on a dynamic basis, not static, and none of them is considered best. We must know the limitations of each score. And SOFA 2 is newly derived and it requires additional external validation. Probably in the next sepsis guidelines, we might have some recommendation related to SOFA 2. And organ dysfunction scores are used for clinical guidance, and we can use other disease specific or organ specific scores as well. Thank you.
Thank you, Dr. Shambhavi, for an excellent talk. Now I welcome our next speaker, Dr. Vinamra Tiwari. I request you to please share your slides.
Yes.
So Dr. Vinam Tiwari is presently working as consultant in Tirthankar Mahavir Medical College. He is also holding the post of Deputy Medical Superintendent. He is an international affiliate of Royal College of Anesthetists, and he is AHA certified BLS and ACLS instructor. His special area of interest include POCUS and critical care. He also has interest in ultrasound guided nerve blocks and focus assessment of transthoracic echo. He has more than 10 publications. So now I welcome Dr. Vinamra Tiwari to give his talk on the nursing workload in ICU. Thank you.
Thank you, ma'am, for the introduction. Am I audible?
Yes, you are audible.
Okay, thank you. So, good evening, respected seniors, dear colleagues and friends. I'm going to proceed with the slides now. So the disclosure is that I have no financial disclosure or conflicts of interest with the presented material in the presentation. So my topic for today will be dealing with a crucial yet a less discussed issue, which is actually playing an important role in making ICUs and HDUs work in an efficient manner. There are various codings on which we have already discussed by now. So now we will be progressing to introduce quantitative methods which measures and quantifies the nursing workload. And they help us in, like, as in we are doctors and admins here. So they help us in enhancing the overall efficiency of the ICUs. So to ask this, that why this topic matters, because severity is not just physiology, pathophysiology specifically, it is also how much care a patient consumes. So the traditional severity scores like Apache and the scores which we have already discussed, they predict mortality but not staffing demands. Two patients with identical sofa can have vastly different nursing roles. And ICU bottlenecks, we all know that burnouts are a real events these days. So adverse events often occur due to mismatch between the patient workload and nurse availability. So the need for workload-based assessment is a necessity these days. So what is nursing workload-based severity? A method of estimating patient severity by quantifying nursing time, effort, and intervention intensity. These scores do not judge nurse performance, but they quantify the number and complexity of interventions, monitoring intensity, therapeutic burden, and they are mainly used for staffing justification, ICU capacity planning, cost, resource benchmarking, quality and safety analysis. So to start, before this slide is very important for us to understand, because this is going to give us a picture of why nursing workload is important. So consider this, where there are three different scenarios. The first case of a stable, ventilated patient who has a higher Apache score, but moderate nursing workload, right? And the other case is of delirious NIV patient who has low to moderate Apache score, and this patient has a very high nursing workload. And the third case of a patient who is on ECMO, for example, and of course the patient will be having a high Apache score, but with extremely high nursing workload. So if you consider in these three examples, two cases, that is the first and the third, the Apache score is pretty high, but the nursing workload differs from moderate in stable ventilated patient to high as in the case of the patient who is on ECMO. So from this, the final inference is that the mortality is better predicted by the cumulative inputs from the scores like Apache, as well as from the scores of the scores which we will be discussing later on the slides. So for example, we have this TISS, which we are going to discuss later on, NEMS and NASCOS. So why, before starting anything, we have to discuss these 5 parameters which are very necessary to understand the evaluation of ICU. So I would just like to hasty discussion on these parameters. The first is the process measures, in which The evaluation is done for the processes like antibiotic stewardship, mobilization of the patients, hand washing, DVT prophylaxis, etc. In the quality metrics, we have ICU SMR, like standardized mortality rate, as ma'am has just already discussed, hospital SMR, sentinel events, CLAPC, CORTI, VAP, etc. In the efficiency evaluation, the ICU length of stay, hospital length of stay, and variables like ICU occupancy, bed turnover are monitored. For evaluating experience, the patient satisfaction is taken, the family satisfaction is taken, delirium rates are evaluated. And in the other methods of evaluation, we have like the trainee performances, the publication, the research, and the nursing severity, the nurse workload severity, which we are going to discuss now. So the first scoring system, that is therapeutic intervention scoring system. So what is it actually? It is quantitative scoring system, uh, which is used to measure therapeutic interventions delivered to critically ill patients. It was introduced in 1974 and it has undergone various modifications since then. So the original TISS 76 was introduced in 1974, as I have already discussed, but it was too complex at that moment. So modification was needed that was done in 1996, and the modification was known as TISS 28. This was simplified and ICU friendly. So what it helps in? It helps in research use, resource allocation, and clinical use. So this is going to capture well the monitoring and the procedures with the patient, the ventilation of the patient, and the drug administration. The key drawbacks for the TISS 76 was that it was time intensive. It was not always the most effective predictor of mortality, like in obstetrics. Interpretations can vary between raters, affecting consistency. So next we will be going to discuss this TISS 76 score. So as you can see, there is a whole list of 76 items on the screen right now. Uh, so just to get detail on the third point here on the second column. So if you are going to count all the items in this list, the number will be coming to 74. But that is because if you see the third point here, emergency thoracocentesis is written, after which there are two more points, that is paracentesis and pericardiocentesis. So that is going to make a 76 pointer score. So TISS 76 items are assigned points from 1 to 4 based on the intensity or complexity of the care. So the points are summed up over the 24 hours to get a total TISS score for that patient. This is TISS 28. It was developed to simplify the quantitative analysis as well as to reduce the burden of complexity in documenting and assessment. This tool captures similar level of therapeutic activity and nursing workload as compared to the more complex 76. Thus, TISS 28 serves as a reliable, simpler tool for estimating nursing workload and staffing needs in the ICUs. The next score is 9 equivalents of nursing manpower use score. So, what is NEMS? It is a simplified score. It uses 9 high impact key ICU activities like ventilation, vasoactive drugs. Indicators are weighted with points from 3 to 12 points each. They are again summed up as in the previous scoring from 0 to 56 points per patient per shift. In this, the one point is equal to 10.6 minutes. So we are seeing for the first time that the points are actually equated to the minutes. Why was it developed? Because it was faster scoring than TISS 28, easier for routine ICU use with reduced documentation load, as the number of items are reduced in this, and suitable for administrative benchmarking and because of the better compliance and repeatability. Where it fits the best. So in the staffing models, followed by inter-ICU comparisons and the daily workload estimations. So the key takeaway is that 9 equivalent manpower scoring is efficient but tends to underestimate the true nursing workload and also a weaker link to actual nurse staffing cost compared to the next scoring, that is nursing activity score. So I just skipped this slide where we will be seeing this NEMS score. Progressing to the next, nursing activity score. Why nursing activity score matters? Because it was developed to overcome the limitations of TISS. It measures percentage of total nursing time per patient per 24 hours. So NAS is efficient in estimating true nursing workload as compared to NEMS. So to understand an NAS, if nursing activity score is equal to 100%, that means that one patient is occupying the full nurse, like one full nurse is being occupied in the care of the one patient. If the NAS is approaching 50%, then it means that two such patients per nurse. And if the nursing activity score is more than 100%, that means that 1:1 or more than one nurse is needed per patient. It is easy to implement because it converts directly to nursing patient ratios. It actually also it was also good for staff shifting plans and surgery plannings, search plannings. And it is strongly correlated with the intervention intensity, better reflects real ICU nursing work. This is the NAS score, and as you can see, that it identifies activities. Nurses use a checklist to record the specific nursing task performed for a patient. The assigning of points, each recorded activity is given a specific point value determined by extensive research to represent the average time spent on that task over 24 hours. At the last, the points are being summed up. The total NAS score for a patient is the sum of all 3 points, all these points from all activities recorded within the observation period. There are a few other scores which are left for the discussion. That first, amongst that, the first is that ICNSS, that is Intensive Care Nursing Scoring System. It quantifies patients' needs to determine the nursing workload. It assesses 15 areas like vital functions, mobility, pain, and family distressing, assigning them with points from 0 to 64. Higher scores mean more intensive care, helping adjust nurse-patient ratio uh, from 1:1 or 1:2, whatever the need is. It is used alongside medical scores like Apache 2, SAPS 2 to provide comprehensive view of care needs. There's also another score which is NASA TLX, as the name suggests that it was made by actual NASA. And NASA TLX stands for NASA Task Load Index, is a widely used subjective tool for assessing mental workload by having users rate the task across 6 dimensions. The first dimension which is being measured is mental demand. How much mental thinking slash calculating was needed in that task. Second is physical demand. How much physical activity was required. Temporal demand. How much time pressure was there. Effort. How hard did you have to try for that work? And performance. How successful were you in the completing the task? Frustration. How insecure or content did you feel? So rating scale. Each subscale uses an interval scale from 1 to 20. Overall workload is calculated by weighing the subscale ratings based on the participant rankings, providing a comprehensive view. It evaluates workload performance for research and admin purpose in various settings like in cockpits, control rooms, also including the healthcare like in nursing. So how workload-based severity translate into ICU decisions? Uh, Practical applications to be considered are that dynamic nurse-patient allocation. If we need to justify the 1:1 nursing, these sports helps a lot. ICU expansion proposals, burnout prevention, as we have already discussed this thing before, quality and safety indicators, cost per ICU day estimation, because we all know that interventions are going to cost a lot, and that can be estimated by these estimations. So, stronger correlation of ICU adverse events with nursing workload rather than illness severity alone is a key takeaway from this slide. The strength and limitation, the strengths are making it makes nursing work visible, like the interventions which which is needed on a patient. If we are going to score them, we are going to know what the nurses are doing, right? So this is the strength. Objective staffing justification, improve safety planning. The limitations being that the documentation burden is increased, as we all know that nursing are already burdened with the paperwork, but this adds to it. Training need for consistency. The pickup of the scoring needs planning and training, which needs to be reinitiated. So the training part is very important, and no tool captures everything. So it has to be used alongside, not instead of physiological severity scores, is the key takeaway from this thing. The take home message is that ICU severity has two dimensions, that the physiological risk, that is that is going to govern the mortality, and the care burden that is being assessed by the nursing workload. So the optimal ICU management requires both. That is which we have already discussed, and the scoring system which we have discussed has progressed, and it has represented an evolution towards real-world staffing intelligence. So to close all my discussion is I'll be closing with this statement that in modern ICUs, beds do not run ICUs, nurses do. And nursing workload must be measured as rigorously as patient severity. Thank you for the time.
Thank you so much. Thank you, Dr. Vinam, for that insightful presentation. It really highlighted the often overlooked aspect of the nursing workload in our ICUs. So as we come to the end of the session, I think we can all agree that while the scoring system seems just like number or calculation, it is actually the language of quality care. Whether it is predicting the mortality with Apache, tracking organ failure with SOFA, or managing tests, these tools empower us to make better and more objective decisions. So with that, we conclude the session and we'll go for Q&A session.
Thank you, Dr. Pallavi, for a wonderful session on scoring patterns in intensive care. There are no questions as far as I can see in the chat box as on date. Actually, why no questions are there is because most of the people watch the webinar on the YouTube, and the questions actually do not come because of that. And that is probably the reason. It was a very interesting webinar, and I'm sure everybody must have gained from this webinar. And I would like to thank your team for organizing a wonderful webinar and educating all of us. Thank you very much for that. And before we close, I'd like to remind everybody about the National Conference of the Indian College of Anesthesiologists, which is going to be held from 11th to 13th of September at Aligarh. Please do join. All those who are hearing this webinar, please join. I'm sure you'll all benefit from the conference, and you will have a good time at Aligarh also. I would also like to remind all of you to keep encouraging your residents or your junior colleagues to submit original articles to the Journal of Indian College of Anesthesiology, JICA. And I can assure you very soon JICA would get indexed. We are already in the process of indexing it into DOAJ. And as we proceed further and we start getting more submissions, I'm sure we'll also get indexed into PubMed. And people who submit articles even now, their articles even now, whenever the PubMed indexation occurs, their articles will be considered as PubMed indexed articles only, because it's always a backdate indexation. So thank you very much once again. Thank you, Vineet, for organizing everything from the end of the college office. And thank you, Ria, for hosting us. And thank you, ClearNet. Good night, everybody.
Thank you, sir.
Thank you so much, sir. Thank you, sir. Good night, sir.
Thank you so much.
I just want to know how the attendance is going for our webinars. Can you help us in finding out that?
Absolutely, ma'am. I'm just informing this information to the coordinating person, and she will let you know as soon as possible. Okay, ma'am?
Okay, fine. Thank you very much.
Thank you.
Thank you so much, ma'am. Thank you so much, everyone, for extending us the opportunity to host the session. With all due permission, now I am closing this session and looking forward to hosting you again.
Okay. Thank you.
Thank you so much,
everyone.
Okay, ma'am. Good night, ma'am.
Good night. So we are wrapping up this session here. Stay safe and have a great time.
Okay. Good night.
Good night.